Welcome everyone. My name is Katerina. Today I'm going to be the moderator of the training. We continue. We have the new topic, psychopharmacology and the battlefield or in battle conditions. Our lecturer, Colonel Chris Warner, the lecture is planned for 1 hour, and after that we're going to have Q&A session. You may raise your hand or write your question in the chat. Let me remind you that this meeting is being recorded and you would be able to watch it later at Forepost YouTube channel. Also, we have simultaneous interpreting. To listen to the interpreting, you should go to Zoom settings, press the globe and press the relevant button. And now, Chris, the floor is yours. We are ready to start.
Chris, can you go to the English channel? At the bottom should be a globe. You can click on the English channel.
There. Can you hear me now?
Perfect. Yes,
Okay.
perfect. Thank you.
Can you hear me? This is interpreter Christopher. Yeah, you can hear
Yes,
me.
now I can hear you.
Okay, great. So the moderator has introduced you and the floor is yours.
All right. Thank you. Hello, everyone. My name is Dr. Chris Warner. I'm a retired U.S. Army psychiatrist who spent over 3 years in Iraq and Afghanistan during my career, and looking forward today to talking to you about the use of psychotropics in a combat zone. Next slide. So over the course of this discussion, we'll talk a little bit about the history of what we've seen within the United States of the use of psychotropics in a combat zone, talk a little bit about how the policies have developed, who prescribes within the United States, some of the unique challenges we found. I'll go through an example potential formulary to consider and talk about some of the lessons learned, and then close by covering out some of the ethical issues that we've seen during this time. Next slide. The use of psychotropic medications in combat dates back to ancient times. Even the ancient Egyptians and Greeks used opiates to help sustain and enhance bravery. Within the United States, our history of the use really begins over the last 100 years. During World War II, both Ally and Axis forces used amphetamines, including the United States, to help stave off fatigue and drowsiness and improve concentration and focus. As we moved into Vietnam in the 1960s and 70s, we continued to use stimulants to again help especially those that were out in small isolated units and that were going to be operating for prolonged periods of time to stay focused and stay awake. We also looked at the use of sedatives to help improve performance, especially in anxiety-provoking situations such as paratroopers or younger soldiers. But the majority of what was used on a routine basis were either treatments for insomnia or acute anxiety. And those came in the form of either tranquilizers, which would have been first-generation antipsychotics such as Thorazine, or in the form of benzodiazepines such as Librium or Valium. We did not use antidepressants at that time. As we moved forward into the 1990s, where we were doing operations in Somalia, Bosnia, Kosovo, this of course also coincided with the introduction of the selective serotonin reuptake inhibitors such as fluoxetine, paroxetine that were coming on the markets around the world. And at this time, we started to have discussions about whether these would be viable or usable in that environment. However, at that point, we were not deployed for prolonged periods of time. We were not sending folks back to the same zones on a repeated occasion. and our service members were not facing combat situations on a routine basis, and therefore this was never really challenged. And we continued to see the existing policies of discouraging the use of treatment. Really, where we saw a significant evolution was in the early 2000s with the advent of Iraq and Afghanistan. We were suddenly sending an all-volunteer force into combat scenarios and situations. We were redeploying them back and forth for year-long rotations so that they were coming in and out of these combat zones. And we were also seeing that we had a higher number of individuals who were already reporting existing mental health conditions as well. So challenges became as to how do we manage these, not only after deployment, but how do we also manage these while the individuals are deployed and in the combat zone. Next slide. And for us, the big turning point actually came in 2006. So prior to 2006, our policies really focused on discouraging the use of medication other than for things such as acute treatments and really trying to calm someone down or help them get to sleep. In 2006, for our in-theater management, our guidelines for the management of combat and operational stress now saw the value and the potential benefit of maintaining our fighting force by doing ongoing treatment and therapeutic modalities in theater. It also saw the value of being able to manage existing mental health conditions in the combat zone as well. Having been deployed multiple times between 2005 and 2010, we were identifying new onset depressive mood disorders, anxiety disorders, and trauma and stress conditions, and would not only manage with medications, but we would also provide some levels of therapy and treatment in the combat zone, depending on the circumstances. And we'll talk a little bit more about selecting that here a little bit later on. But we would also have individuals that were previously identified with depression that had been stable on a sertraline or a paroxetine or a fluoxetine, or someone who had generalized anxiety disorder, that we would deploy them and continue to monitor and care for them. This led to a second challenge, which was the creation of deployment limiting criteria. So what would be acceptable to deploy, what would be acceptable conditions to manage. And so the first iteration of that policy was developed in 2006. And this looked at trying to define what would, based off of our resources and in considerations, what were the absolute conditions that we would never deploy, and what were the things we should consider. And we'll get a little bit more in depth in that in a couple slides here. A key aspect to that, though, was the fact that there needed to be an assessment. And so shortly after these criteria were developed and rolled out, we did assess that by actually comparing those who had gone through the new screenings and those who did not. And what we did find was those who we sent on deployment, who were managed and continued to be monitored with existing conditions, actually fared much better than those who had not gone through any sort of screening and were not going through any sort of management protocol. The reality was we knew that if we were not doing this, we were still probably deploying some with existing conditions, but then they were not being managed and monitored. And the reality is we were also just contributing to stigma of those not seeking help when they did have new development. By creating a system and encourage those to get help earlier, and allowed us to manage that and decrease a lot of the negative outcomes while keeping our individuals engaged in the fight. Now, it's important to note that none of these have outcome data as to how that impacted them later in life with the onset of PTSD or in terms of severity later in the course of their, in their veteran status. This has all been focused on what we can do to maintain the fighting force at the time. Next slide. So one of the keys is who can prescribe. And so for the United States, for the United States Army and the United States military, there are some limitations, but in general, all of our physicians, our physician assistants and nurse practitioners are capable of prescribing a basic level of psychotropic medications. They can use sleep induction agents such as a zolpidem. They can use first-line selective serotonin reuptake inhibitor treatments such as a fluoxetine or a sertraline, and they can do basic anxiety and depression management. We would look to our psychiatrists, who are a little bit more limited in our deployed environments, to look at the more difficult and challenging cases, the more treatment resistant, and especially dealing with the acute psychiatric emergency type cases that would still be evacuated. To be clear, we do not manage severe cases or unstable cases within the combat zone. Those would be ones that we would evac up through our medical echelons of care. But we do, especially at the Role 1 and Role 2, have the ability to do just continued management of depression, mood, and trauma and stress that is stable. And by stable, I mean we're not dealing with acute suicidality. We're not dealing with psychosis or mania. Those would be all conditions that your psychiatrist would do acute stabilization and then evac. It's also important to note the role of the commander in this process, because here we're talking, as we look at some of these policies, about deployability, about who stays and who goes. Those are decisions within our system to the commander. The commander makes the ultimate decision whether a service member can deploy or not. And the medical's responsibility is to give the diagnoses, the medications, and the expert recommendations. But the decision to deploy still rests with the commander. Next slide. So getting specific into a little bit about some of the deployment guidance. That column on the left outlines the major conditions that were the deployment limiting, and then you can see a breakout on the criteria. So first of all, certain diagnoses absolutely meant that you could not deploy, and those would be any history of psychosis or bipolar. I think that's probably self-evident. Having taken care of several actively psychotic and actively manic patients in the deployed environment, there are just so many safety concerns associated with that, and it's not worth the risk. As you look to more just your primary diagnoses, what we looked for was a period of stability. So for somebody who had depression or anxiety, we want to see 3 months before they were to deploy, 3 months on medications, doing well, and being stable. And that meant no side effects from the medication. That meant their depressive symptoms or their anxiety symptoms were well controlled, as defined by both the subjective evaluation and what we were seeing on their objective data from our scales that we would use to monitor. And then we would be comfortable going ahead and clearing them medically for deployment. The third category was medication monitoring. So the rule of thumb would be is if it requires blood levels to make sure that they're in a therapeutic window, this is not an individual who should be deployed. As many of you are probably aware, there are not a large volume of psychotropics that require this. And many of them have overlap with the non-deployable diagnoses. For example, Depakote and lithium are most commonly going to be used in treatment of bipolar disorder. Those require lab monitorings to make sure you're in the right therapeutic range. Those would just be two different reasons to not be deploying someone. But it is not just about the diagnosis, it's then about the monitoring requirements, because you may not have reliable lab capabilities, or in the condition of something like a lithium, which is a salt, putting them in severe environmental conditions such as a desert with very hot conditions and limited water, they could become nephrotoxic on the lithium just from the environmental conditions. The fourth category was antipsychotic medications. So in addition to those that required monitoring, the atypical antipsychotics, so things such as aripiprazole, olanzapine, quetiapine, those would all be contraindications to deploy. Again, many of those are primarily used in treatment of psychosis or bipolar, but over time we have also seen off-label use of those medications in folks who might have post-traumatic stress disorder or some treatment-resistant depression. And so if they're requiring that level of medication management, then this is someone that we don't expect to stay stable and we wouldn't want to deploy. The next two categories are looking more at the medications themselves. So if it's a medication that has, it could be potentially, they're not going to be able to get in theater, that they're not going to be able to manage, or that has other potential risks, such as short half-lives, risk for withdrawal, or we don't want to take the risk of the abuse of having large quantities of those around, then that would be one that would have to be considered. And then lastly, again, the psychotropics, any of them, you're looking for a period of stable for 3 months. And so again, you see a lot of overlap between these categories. You want their condition to be stable for 3 months, but you also want the medication that they're on to be stable for 3 months, because you want to make sure they're not having significant side effects or issues. And then what we found in that last block was we would have a number of sites that would actually limit even further what they would be willing to have deploy within their area of operations. So a common one would be the treatment of ADHD. You would have individuals who might be on either a bupropion or an atomoxetine, or they might be on some level of a stimulant. These would not necessarily not meet those upper criteria, but you might have a zone that does not want to have folks coming into their area with those particular conditions or those particular medications, so they might make them more restrictive. Any questions on those before we move on to the next slide? All right, next slide. So I want to talk a little bit about the pre-deployment actions, what would be done before you would want to deploy somebody. And again, this is looking for those with existing conditions. So within the United States, we have a deployment clearance process. This allows us to identify those who meet the minimum standards, the minimum mental health standards for deployment, which I just covered. It also allows a process to case manage. So we want to avoid the idea of just giving somebody 90 to 180 days worth of medication. You also want to have a process that they're going to continue to get followed up and evaluated. Now, we're not talking things like weekly therapy or weekly treatments, but somebody that 1 to 2 months in is going to check up on them. Within our structure, we have, for each brigade, we have 1 to 2 mental health officers who are either psychologists or social workers, as well as 2 to 3 mental health technicians. They would work in partnership with the PAs and medical doctors, primary care medical doctors at the battalion level and brigade level. And then in each division, so approximately 20,000 service members, we would have one psychiatrist. And these individuals would be managing and ideally monitoring and reaching out. They weren't necessarily, the psychiatrist doesn't need to necessarily see everyone, but making sure that primary care doctor is pulling this individual back in, checking on them, they're still remaining stable and doing okay, is a key aspect of that case management process and that process for reassessment. Secondly, this allows for the planning, the psychopharmacologic planning for deployment. And we'll talk a little bit about more about this as we talk about particular treatments, but recognizing how much medication should I be taking, what are some of the keys that I need to have with me, may be driven by the service members that you're deploying into the environment and knowing what their needs are. Of course, this is key, and this impacts what you might clear and what you might send, is your ability to be able to resupply, the maturity of the theater that you're going into in terms of how much you're going to be able to maintain, and the impact of the environment in terms of your ability to store. If you're expecting to be in major combat operations where you're constantly going to be lifting and shifting, moving forces, you're going to have a much higher threshold of what you're willing to keep in theater or take with, mental health conditions to take into that environment, because you're going to have less capabilities you can maintain. As you move into more phase 4, phase 5 stability operations, and you're holding area and you're trying to make transitions, this is a time where you can accept more risk and bring more of, and keep more of your mental health service members in the area and maintain them in a stable manner, because you will be able to have better supply lines, supply chains, and be able to maintain a ready supply of medications. And again, just to hit the foot stop again, the lab monitoring, you're probably never going to have the lab monitoring capabilities you need for those medications. And so would just not maintain, keep, or deploy individuals who require lab monitoring for the medications that they're on. So I'm going to transition this now into a discussion about a screening process. This is not, this is a way to do it that just gets after that deployment clearance, but to help show you how this works. Next slide, please. I'm just waiting to see the next slides come up. There we go. All right, so this flow chart just walks through one potential process of how you can enact a pre-deployment screening. So it starts by just building some level of general screening tool. In our case, it had approximately 15 to 20 questions that asked about any prior history, current medication treatment. It also included some basic screenings looking for the presence of PTSD and depression and substance use issues. So if the individual fills out the form, then they meet with their primary care provider, who reviews the responses. If the soldier doesn't have anything, no history of mental health conditions, they're not on any medications, they're not screening positive for any of those conditions, they're cleared for deployment. However, if they do have positive responses, then we have them meet with a mental health professional who reviews and applies the minimum mental health criteria for deployment. So in this case, service member 1 has a 3-year history of depression. They've been on fluoxetine for 2 years. They have no side effects. They've been doing well. and they've never had any history of a worsening of beyond moderate level symptoms of depression, and they have been with a PHQ-9 score of less than 8 for the last 12 months. And so this individual meets all of those minimum mental health standards for deployment, and therefore would be labeled in that far left orange box of the soldiers fit for deployment. So in that case, the soldier deploys, and then the unit would track them out. In contrast, Soldier 2 will go down this far right lane. Soldier 2 is an individual who was diagnosed with bipolar disorder after a manic episode 2 months ago, is currently on aripiprazole and Depakote, and comes in, is having significant side effects with their medication, and has not been at a therapeutic level on their lab monitoring for their Depakote. And so this individual fails to meet several of the criteria. They've got a non-deployable diagnosis with the bipolar. They're on a medication that requires lab monitoring with the Depakote. They're on an antipsychotic medication with the aripiprazole, which makes them non-deployable as well. And they've just had a major event in the last 2 months, so they don't have a pattern of stability as well. So all of these things, clearly make them unfit for deployment. And we don't see this being an individual that's ever going to be able to deploy. So this individual would go into that far right. The soldier's found unfit for deployment, goes back to the unit, and the unit makes the decision not to deploy them. There is a little bit of this gray area that's in this middle lane. So in this case, we'll use an example of Soldier 3 recently was diagnosed with major depressive disorder and generalized anxiety disorder 2 months ago at a moderate level, a PHQ-9 score of 14, a GAD-7 of 12. The individual was started on venlafaxine or Effexor approximately 6 weeks ago, is at a dosage of 75 milligrams at this point, and their symptoms, their PHQ-9 score has now dropped down to a score of 7, and their GAD-7 is a score of 6. Individual says they're responding well to the medication. The only side effect they're complaining of is some decreased libido. In this case, this individual does not meet deployment criteria right now. The individual has not been stable long enough. The individual has not been on, it has not been stable on the medication without side effect long enough. But at this point, there can be a request that you might that we may want to go ahead and find them fit for deployment. The individual's already doing well. They've shown no signs of, they only had a moderate level of condition to begin with. You could look to want to seek a waiver to deploy them early, or you could make a recommendation that we'll hold them for a few more weeks and then deploy them late. And so that is what we looked at with the waiver process. But those decisions then would be evaluated by the senior medical advisor within the deployed environment as to what medical risk and capabilities might factor into that, and have them make a recommendation. So this was a process that's a little bit more formal. Again, that center block is really for a mature theater, where you're expecting large turnover and transition. This was most significant for the United States with our Central Command, with the large volume of forces flowing in and out of Iraq and Afghanistan back in the 2005 to 2012 timeframe, where we had large volumes of turnover, we had large number of demands, and we needed to balance what were the capabilities with what were the requirements. Next slide, please. So there are multiple factors that go into, so we talked first about this, what do we do for screening, who we need to send. Now I want to talk a little bit about that planning for what you'll do and what you need to take, and some of the factors that go into the medication management. So the first is just looking at how are you going to be able to dispense medications in the deployed environment. First and foremost, what is going to be your resupply capability? If it's going to be very hard to get medications, then you're probably going to want to take a lot more with you during your initial during that medical unit's initial deployment. There's got to be some mechanism for connecting the providers who are actually prescribing these medications with the supply chain and the people in there, so they understand what's happening, and it may cause them to change their patterns. So for example, we're in the deployed environment, we have access to, and this is just notional, but we're maintaining 3 selective serotonin and selective serotonin norepinephrine reuptake inhibitors. So we're going to have fluoxetine, sertraline, and venlafaxine, and those are our only choices. And we know that we're starting to run very light on the amount of venlafaxine we have. We need the prescribers to be aware of that, because they may need to start changing their prescribing habits as to what's available, because the last thing we want to do is get somebody stabilized on a medication and then have to switch them in theater, or we don't want to build a therapeutic alliance between that prescriber and the patient and then tell them, oh, but wait, we don't have this, now we're going to have to switch to this too. So keeping that communication channel available and working through this is key for allowing that to be successful. Also involved is the idea of security and storage. Most of the mental health medications that you have are not controlled substances, but there will be some. The benzodiazepines, the stimulants will have to be locked, monitored, and closely accounted for. And while most of the medications don't require special storage, there are some that you may need a small refrigerator for, or other capabilities. So your ability to securely store and to safely maintain power to environmentally control may impact what you're available to take. And so those will be part of the assessment that the medical team should be looking at when they determine what is going to be in their formulary that they'll have with them, and then should also feed back into what you should be willing to let deploy then. And then as we look, you also have to consider those factors at the bottom, which is just because we're going to have these capabilities there in theater, just because you're going to have a formulary, there still has to be how accessible is it for the soldiers to access, to be able to go back and get. What's the process for them getting a refill? How do they have to go to that? What is the proximity for other services? And then also, when considering who you would actually treat in the deployed environment, also goes into what's the reliability that the individual is going to actually take the medications, is going to be compliant with them. I would tell you this should also influence a little bit about some of the prescribing choices that are made as well. And we'll talk a little bit about that here in the next slide as to where are some of the places that might come into in shaping the choice. So, next slide. All right. So I'm going to take a few minutes here and go through some of the things to consider and some of the medications to consider in a deployed environment for treatment of various conditions. So we'll start with mood disorders. Nope. I'm sorry, did somebody have a question? Okay.
Богдан, у вас рука піднята. У вас є питання?
Bogdan, you have your hand up. Do you have a question? Yes, I do have a question. But on previous slides, on one of the slides, you said that there is experience of using antidepressants to prevent mental disorders that may arise in combat. And it is interesting because when I talked to two military psychiatrists from Yale University, they said that no such trials have been held. And I wonder if that they did take place or not. Could you comment on that?
So there are no trials that have been done that look at whether treatment in theater and in the combat zone will prevent the development of long-term conditions such as PTSD and such. The study that we were referencing, and I'll be happy to share the actual article. It was from the Psychiatric the Annals of Psychiatry in 2011. It looked at the effectiveness of deployment limiting criteria and pairing that with a case management process to decreasing negative outcomes during the deployment. So it was about the reduction of the negative behaviors. It wasn't about the prevention of combat stress or of these conditions from developing, but it was about more effectively managing the severity so that you reduce suicides, you reduce days lost from work, and you reduce things such as overdoses or medication issues.
У нас наразі є одне питання в Q&A.
Currently, we also have one question and Q&A. I don't know if we can address it now or maybe at the end after your presentation. What's more convenient?
Let's get through this and then we'll open up the Q&A as long as is needed so we can, in case we might answer the question before we get to the end. And if we haven't, then we'll go ahead and continue with all the questions. So, all right. So we'll talk here briefly about mood disorders. As mentioned earlier, bipolar is not something that we would manage in a combat zone. However, it is not outside the realm of expected that you may see a new onset manic episode in a deployed environment. And so you do need to have capabilities to be able to manage, but your goal should be acute stabilization and immediate evacuation. The first line treatment for bipolar disorders and specifically mania would be your atypical antipsychotics. And so as any medical unit that is planning what they would want to have on formulary, I would recommend at least 2 atypical antipsychotics are available, and at least one of those should be in an injectable form. And I'll have a rundown here a little bit later on, but for your acute stabilization, again, bipolar, immediate treatment to sedate them and evac. For major depressive and dysthymic disorder, the treatment is first line treatment, of course, are the selective serotonin and norepinephrine reuptake inhibitors. These are medications that are generally safe to use in a deployed environment, as long as these are something that you would have the ability to continue to have a reliable supply of, and that you have the ability to monitor the individual. So this is something you might, depending on the level of severity, be able to manage and continue to keep the individual there in the environment. Now, when you start thinking about which medication to use amongst those lists, there are some things that should be taken into consideration. Of course, first and foremost would be what you have available and that you would be able to continue to get. But as you start looking as to what you might consider that you would want to take, sertraline or Zoloft and escitalopram, which is Lexapro, they have low levels of interaction with other medications. So those are some of the what you might consider cleaner medications to use. Prozac or fluoxetine has a very long half-life. Service members may lose their medications. They may forget to take them several days. So it's going to have a lower incidence of antidepressant discontinuation syndrome. So this is a good choice to use as well. In contrast, something like a paroxetine has a very short half-life. It's going to have a higher incidence of antidepressant discontinuation syndrome. It also has a lot of anticholinergic effects. So it might be one in certain environments that I would want to decrease my use of. So again, this is driven by what you have available, what you can reliably resupply, and then considering your environmental factors and your soldier population. I would recommend, so the recommendation would be is you at least have 2 or 3 in your formulary of the SSRIs and the SNRIs. In addition to those, we would recommend that you also include bupropion and potentially mirtazapine. Bupropion is another antidepressant medication. This could also be helpful for attention and focus. And depending if there's a desire to do smoking cessation, it is effective for that. Again, smoking cessation is not something I would be considering unless this is long-term stable environment where you're now looking at some preventive health interventions and a controlled populace. These were type of things that we were seeing in Iraq in 2008, 2009, in Afghanistan, 2015, 2016, 2017. It would not be something I would be looking at doing during major combat operations. For major depressive disorder and dysthymic disorder, I would recommend against any use of tricyclic antidepressants. They have significant side effects. Also, there's a significant overdose risk, and some of them may require lab monitoring. Next slide. Looking at anxiety and trauma and stress disorders, again, the SSRIs and the SNRIs are the first line treatments. So much of this is exactly like we were talking about with major depressive disorders. The nice thing is that having 2 or 3 allows you the flexibility to be able to manage all of those conditions with similar medications. You would want to consider having a supply of benzodiazepines for the treatment in acute stress or some panic, or potentially to help very briefly with sleep. There are some cautions about this. First, of course, these are medications that can be addictive and can be abused. They do require more special security and storage. Additionally, would recommend caution in treatment of PTSD because they may increase the severity of PTSD. So it's not something we readily use, but we do have available for that very agitated or highly irritable individual that we need to calm down briefly. And then lastly in this group, I would also recommend you consider having an alpha adrenergic and a beta adrenergic antagonist, which can help regulate some of the autonomic symptoms. So a propranolol, which might help for somebody who's having a lot of anxiety, or a prazosin, which would allow for not only the anxiety, but help with nightmares that might be occurring from some of the trauma that an individual experienced. Next group would be psychotic disorders and acute agitation. This will be very much like the bipolar. The goal here is not long-term treatment. It is acute stabilization. This may be an individual's first psychotic episode, or this may be a severe case of agitation where the individual's not redirectable, and this might require some initial sedation and treatment. So you do want to have some level of injectable capability. We tended to keep injectable Haldol and lorazepam. Those are generally relatively easy to store. They don't require significant amount of preparation as opposed to some of the newer medications. There are some oral medications now, such as the dissolvable, that might be something to consider depending on your ability to manage that and the storage requirements. But those would be ones that, what are quick and easy ways to get medications into an agitated patient that you need to get calmed down enough so that you can then evacuate them safely for both them and the evacuation team. For us, much of the evacuation was done via helicopter, and no pilot is going to want a severely agitated patient on their helicopter, because it's putting the entire helicopter at risk. So looking to make sure we've got some level to get them sedated and calm enough that you can get them to a higher level of care and out of the combat zone. So with that in mind, we'd look at what you might consider is one or two of the orally administered atypical antipsychotics, definitely one injectable antipsychotic or neuroleptic such as Haldol, and one injectable benzodiazepine. Generally, I would also recommend that you have some level of an injectable diphenhydramine if you're going to do it. So our typical dosage for an injectable would have been 5 milligrams of Haldol, 50 milligrams of Benadryl, and 2 milligrams of lorazepam as what we would give as an injectable to an acutely agitated patient. The inclusion of the diphenhydramine helps protect you from a dystonic reaction. Next slide, please. So the last group I'll cover in terms of just conditions is the presence of insomnia. We know insomnia is a significant condition that presents in a deployed environment. It can be due to a primary condition. It can be due to the operational stress. It could just be an adjustment reaction that's going on. The first line treatment should be cognitive behavioral therapy for insomnia. And many times it's just the initial combat operational stress control, which we've talked about with you previously, that may be effective. But if you feel that there are reasons that you need to help use medications to get someone to sleep, this may be due to their duties and responsibilities. It may be other factors that you look at that you need to use meds. There are also reasons why you may not use meds. If they have a significant substance use history, or they have they're not good at adhering to staying on medications, then you may not want to use this. But if you assess that medications are right for the individual, then the 3 or 4 that we would recommend that you have is, one would be trazodone. This is usually good for helping individuals who have difficulty staying asleep. So not only does it put you to sleep, but it generally has you sleeping for 6 to 8 hours. The advantages are that it does not decrease your, it helps actually maintain your sleep architecture. The negative to it is long acting. And if this is an individual that needs to be able to get up and moving at a moment's notice, this is not the right medication for them. Benzodiazepines can be helpful, but should really be limited to very short-term use. sleep induction agents, so a zolpidem or a Rameltian or those such medications, they may be helpful for isolated insomnia. So those who are having a lot of circadian dysrhythms, so you just deployed halfway around the world and sleep cycles are thrown off, a couple days of these may help get everybody reset. And then lastly, we talked about this before, was the effectiveness of prazosin for helping with nightmares. I think it's key to note that you don't want to use these as long-term, other than the prazosin. You don't want to be using these as long-term solutions. You're really looking for acute management. Your primary focus should be back on the cognitive behavioral therapy to help people improve their insomnia. But again, this is a balancing one based on how the ability you have to do that and how vital it is that you get them back ready and functioning. Next slide, please. This is an example of a potential formulary to use. So this is what we recommended for our combat stress detachments to take with them in their formulary to have. So just to give you an idea as to the volume that they would take. So not only are you considering what medications you would take, but how many bottles and at what strengths would you want to have available. Again, some of this needs to be done based off of what your estimate is of your need and requirement, but a significant one also is going to be what your requirement is going to be for resupply, or your ability to resupply. If you don't think you're going to be able to get reliable resupply on a regular basis, then you'd want to increase these numbers significantly in terms of what you would have, depending on how much you want to manage. But as you can see with the SSRI, SNRI, they're in the first category. This formulary that we would take really was rather robust within that realm where most of them were available, at least at some level of dosing. But it was much less in the way of benzodiazepines or in the antipsychotics and anti-manic agents, because those are conditions where you're predominantly only going to do some acute stabilization and then evacuation. And with your sleep medications and your adrenergic, you should not need as much, but you're going to want to have, with your adrenergic, you shouldn't need as much because this should be a limited group that would require this level. But your sleep medications are going to be one of your heaviest demands because of the levels of insomnia that you're seeing. And then the last one would be the presence of ADHD. And again, that depends on what some of your pre-deployment requirements or criteria are as to whether that would be something you would choose to manage in the deployed environment or not. Again, these are by no means doctrinal. This just gives an example of what we would send out with our combat stress detachments. That said, our combat stress detachments had reliable resupply capabilities, so they could go in this fashion. If it's going to be months before you get resupply, you're going to want more than this. Next slide. The last thing I'll cover before we get into the Q&A is just the understanding of some of the dilemmas for this. And I think this gets back to the one question we had already, is we need to be clear. What we're talking here is about treating people acutely so that they can stay in the fight. This is not about their long-term management or their long-term prognosis. We are unsure as to what they may require in respect to that. And we don't have good data as to whether this makes them better or worse long-term. There's a couple things we could look at that give us a little bit of insight. So we know that if a individual believes, we know that rapid treatment helps individuals. We also know that the perception an individual has impacts their long-term viewpoints as well. So if you're able to feel that you successfully negotiated and processed and got proper closure to this experience, that deployment experience, because you were able to stay there, that may present better long-term outcomes, but we don't know. We honestly don't know, so we are taking risk with these individuals that we're caring for by continuing to treat them in theater. The downside, of course, is if you evacuate everybody that has a mental health condition, you may not have a significant fighting force left, and we're engaged in combat, and as I'm sure you know better than I, you need mass of force to be able to maintain defensive capabilities or execute offensive operations. And so our ability to help keep service members in the fight is key as well. And then this leads to the second dilemma there of whether it is ethical to be deploying individuals who may have had a known history of trauma or a known history of challenges with depression or anxiety into an operational environment where you know they're going to be facing additional trauma and facing additional environmental challenges, which may not be the most conducive to their mental health. And how we try to balance this is by doing those aggressive things such as the case management, to where we continue to engage them in care, we continue to monitor them and be able to help support. And that's how we came to balance those ethical dilemmas. But the reality is we don't have good data to answer the question and provide reassurance that we aren't potentially putting these individuals at greater risk in the future. And so I'll close with that. We can go to the next slide, and I'll open up to your questions and happily stay on as long as you need to be able to answer whatever you'd like to know.
Я маю декілька запитань. Мене чути?
I do have several questions, if you hear me.
Чути, так?
You hear me, right?
Окей.
So,
Чи доцільно використовувати
does it make sense to use antidepressants
ну, скажімо, такі як флуоксетин або сертралін,
like fluoxetine or
в зоні
sertraline in combat, in the place of combat?
So we know that combat is a challenging environment. We know that everybody's going to respond to the stress differently. A portion of the individuals who are in the operational and deployed environment and facing combat are going to show positive stress responses. They're going to act with heroism and valor, and they're going to show post-traumatic growth. We're going to see a group that responds with some negative stress responses that will potentially show depression, combat operational stress, or potentially acute stress disorders. And then we know there'll be a third group that has maladaptive responses, which are, of course, those who are, those are where they might turn to inappropriate things such as drugs and alcohol or disciplinary issues that we're trying to avoid. So much of what we talk about with the combat operational stress control, what we talk about with some of the prevention work that combat operational stress control teams do, is about trying to direct more and more of those individuals in that stress exposure to have that positive stress response. I would not view the use of psychotropics or antidepressants for everybody as a way to do that. I would look at more that antidepressants should be used for the acute treatment of indicated conditions. So mood disorders, anxiety disorders, and trauma and stress disorders. What I am saying is that given the right circumstances, those medications can be safe to treat in the combat environment and maintain the service member in the fight. Now, again, that depends on not only on their response to the medication, but obviously their severity. If this individual's so depressed that they're suicidal, that they're not responding, that's probably somebody that may need to be evacuated. But if you're looking at somebody that's having mild to moderate depressive or anxiety symptoms, they're tolerating them. We start the medication and they're tolerating it well, and they're doing okay. That's somebody we can continue to treat and keep in the fight.
Олеже, ще питання у вас було?
Oleg, and you had another question, I guess.
Можна питання, да?
Hello, I have a question, if I may. Then, well, I checked the list of medications that you recommend. My question is, to what extent is it possible to use pregabalin when providing aid here in combat?
Could you repeat that? I heard use of, but I didn't hear which medication.
Pregabalin.
Pregabalin.
Pregabalin. Okay. We have not maintained that on our formulary, but that I'd have to. I'm not aware of any special storage requirements, and it definitely doesn't require laboratory monitoring. That there could be some benefit to using that. It's not something we have done in our experience, but as long as it's not for a contraindicated condition, then I don't see why that would be inappropriate to use.
Thank you.
Олександре, будь ласка, ставте питання.
Alexander, you're welcome.
Олександре, у вас
This is my question. Thank you for this very detailed presentation, a lot of helpful information there. My question is it ethical now to use psychostimulants in combat? And if it is therapeutic to use cannabinoids?
So for the psychostimulants, there have been a number of studies that have looked about how to make or how to help encourage effectiveness with the use of psychostimulants. We've seen everything from caffeine to other agents that have been used, and I know we've seen them used sometimes in our pilot population to help balance. So it's definitely something that is used, has been studied, especially in some of our special populations, and we can help share some of those studies. As for the use of cannabinoids, it is not something that we have done as our federal government and our military is still has those outlawed. There have been some discussions as to would cannabinoids be potentially effective. And there's also been discussions about use of other certain agents, such as some of the medications such as ketamine. But those are not anything that we are employing at this point in time, as they have, our laws have not changed.
Якщо можна, ваша суб'єктивна думка
If I may, what's your subjective personal opinion about that? I hear about the law and that cannot be broken, but still, what's your impression?
Sure.
Professional opinion.
So there's been some recent studies that have looked at the potential impact of cannabinoids in helping with stress and how they can help with that, especially with some of the memory functions, that I believe it's something we should continue to look at and study. I think that it's something that there's a big push going on here within the United States for more studies of looking at cannabinoids, also looking at some of the other agents such as ecstasy or MDMA, and some of the other hallucinogens, to be able to be more effective as treatments. And there are clearly some potential combat applications to that. But it's something that I think needs to be studied further before we would start to use it. But I do think there is a future role for cannabinoids in this type of environment, for what they can do for especially that acute stress treatment.
Дякую. Якщо дозволите, ще одне запитання.
Thank you. If I may, another question then about efficacy of using psychodyslaptics for PTSD.
So in this case, what we're starting to get into is the more complex, the more complex management of these conditions. So I would look at, are these the individuals that we want to keep in the combat environment if they're requiring that level of treatment? So we would probably look to evacuate those individuals to a higher level of care and look at those levels of treatment versus trying to potentially do those in the combat zone. Right now, our recommendations are kind of the first line agents from our clinical practice guidelines that we would manage there. If it's requiring more than that, if we're needing to get into some of the more emerging or breakthrough treatments, then those are ones that we'd want to do at a higher level of care and not in the deployed environment.
Можна задати запитання, да?
If I may, another question. Alexander, I'm also very interested about that. Your question about psychostimulants, what did you imply when you asked the question? I implied that there is spontaneous use of amphetamines, for example, in combat, right? It is illegal, of course, and this is not allowed, and some hide that fact, but in fact, that happens. I get it, because I saw that there are some guidelines. No, not only. There's also synthetic catenons. Synthetic catenons, we refer to that as Salama alpha, MDPV. So illegal drugs, right? It's not that it's some guidelines. Yeah, sure. illegal, illicit, and we came across synthetic cocaine. I wrote about it. I didn't believe that it existed even, but it seems that exists. And another thing, whether it makes sense to use legal psychostimulants, modafinil, for example, or armodafinil in combat. Thank you. Nevogil, this is how we name it. Yes, same thing. But I wonder modafinil, because Novogil doesn't fit everyone.
So we do use modafinil in certain populations. Again, in some of our pilots, some of our more specialized units, we will use modafinil and some of the other psychostimulants, especially if we're looking to help establish peak performance. Again, these are not something we would do with just our regular forces. And it's really about increasing focus, concentration, and maximizing their that balance with sleep for making sure that they're able to stay effective in what they're doing. So you'll see this in long-range reconnaissance, some of our smaller, more specialized units, some of the units like our aviation units as well. The challenge you were highlighting about the use of illicit substances is definitely something that we have seen, and frankly, I think every military has seen during long-term and ongoing combat operations, because it's the response to stress that's part of that maladaptive behaviors. You see it in the form of alcohol, you see it in the form of illicit substances. I'll just use an example from Iraq. Our service members were told they weren't allowed to have any alcohol in theater, and we were able to limit what they were able to bring. Yet, they worked and operated in towns where they went by pharmacies that did not require prescriptions at all, and they would go into those pharmacies and negotiate with the local villagers who would provide them things. And so we continued to do urine drug testing even in deployed environments to help minimize that. But it was a challenge for us. That's something we were continuing to find.
Я прочитаю питання з Q&A.
If I may, I will read questions from Q&A session. Olesya Borisova says, hello, do I get it right that since 2006 in the US Army you use pharmaceutical medicines to maintain the soldiers' condition for them to continue participating in the combat? How does that actually happen? If I got it wrong, can you comment when exactly you started using this approach?
So I think the approach has been in place for a while. So we have used combat operational stress control teams with our deployed units since the 1950s and 1960s in operations in Korea and then in Vietnam, and specifically in Iraq and Afghanistan, you started to see a change in the mental health requirements of our service members. Stigma had changed within the United States. More service members were receiving diagnoses, more were seeking care. Additionally, this was an all-volunteer force as opposed to our draft force before. So it was an older force, more experienced, but also exposed to more trauma because of repeated deployments. What this So this saw a change in the demands that we had. At the same time, you saw significant changes in the medications available. So the advent of SSRIs and SNRIs in the 1990s provided safer potential treatments that could be done in a more austere environment. So our policy officially changed in 2006, but some of the practices were already changing in advance of that. The policy changes in 2006 were designed to provide more guidelines and control to what was already starting to occur 5 to 8 years prior. So since that time, yes, we've been more aggressively managing conditions in those environments and looking to sustain that force by using more forward medication treatments.
Дякую. І ще друге питання, Крісе, я вас
Thank you. And there is a second question, and maybe, Chris, you can read it in English in the chat.
Використовувати стероїди, такі як тренболон, для швидшого фізичного відновлення на лінії фронту. Який вплив стероїди мають на наші ментальні умови, ну, типу, як ми функціонуємо психологічно на фронті?
Did you find the question?
I'm seeing the question, but it did not translate.
Would you recommend using steroids such as trenbolone for faster physical recovery on the front line? What effect do the steroids have on our mental conditions on the front line?
Steroids are not something we typically use out on the front lines because there are a lot of potential mental health impacts with those. You can actually potentially have some psychosis with those medications, as well as with some of the environmental challenges. So if we're looking at using any steroid treatments, that would be away from the front lines and outside of the combat zone.
Дякую, колеги. Запрошую вас до питань.
Thank you, dear colleagues. Any other questions? Yes, can I ask a simple question? Just for me to understand it better. When you say like more aggressive effect, what do you mean? Or more aggressive reaction?
Are we talking with the steroids?
No. In general. Что в целом, когда им говорят...
No, in general, when you say we do it more aggressively, when you say about some usage of some medication.
Okay. All right. So thank you. I think that may be somewhat of a translation issue. So what I mean by that would be earlier medication treatment, doing it more in a forward environment where we're trying to do things in a more rapid and quick manner to get care delivered out in those forward and combat environments.
Поясніть, будь ласка, термін ізольоване безсоння, якщо я правильно запам'ятав.
Could you please explain the term like isolated insomnia, if I got it right. What is that?
Sure. Isolated insomnia would be a primary sleep disorder. These are individuals, so a circadian sleep dysfunction. Individual gets on a plane in the United States, flies to Kuwait, and is now having difficulty being able to initiate sleep, and is finding disruption, and so that would be a primary circadian sleep dysfunction. Any other of your primary insomnias would be part of that as well. What we're trying to exclude is insomnia due to other conditions such as depression or anxiety and such.
Коли безсоння є моносимптомом, без інших
Donc, when insomnia is a monosymptom without any other symptoms, right?
Yes.
Yep.
Є у нас питання в чаті, прочитайте, будь ласка.
We have a question. Would you comment on your experience promoting adherence during deployment, including the role of unit leaders in promoting adherence?
Great question. So we try to balance letting our unit leaders know about a service member's condition versus giving the service member some level of privacy. But if we do place a service member on a medication, we do let the unit leadership know that we're doing that. We think that is a point in time where they have to be made aware. Initially, we would, and again, depending on the condition, we would not seek to involve the unit leadership on adherence monitoring. If we were dealing with somebody that we're trying to acutely stabilize or we're trying to evacuate, we might look to the unit leadership to help with that. If this is someone that is now shown they're having problems remaining compliant and we need assistance before we can get them out of the deployed environment, then we might look to the unit to help do compliance monitoring. But in general, if this is an individual that's going to require compliance monitoring to be effective, we're either not going to treat them with a medication, or we're probably looking to get them out of the combat zone and seeking the unit's assistance only for the period of time to get them out of the combat zone. And that is different than how we've approached other conditions. So, for example, I was involved with the U.S. military response to the Ebola epidemic in in Western Africa. In that particular deployment, we were very concerned about malaria prophylaxis. And in that case, we did have unit leadership help with adherence by truly having a formation every day where one of the leaders made sure everybody took their malaria prophylaxis. But we do not do that type of level of monitoring with our psychotropics. If that's required, then there probably should not be remaining in the combat zone.
Давайте застрибну з питанням з Q&A. Скажіть, будь ласка, що ви думаєте про препарат налбуфін? Опіоїд аналгетик. Він у аптеках наших.
Could you please tell us what is your opinion about nalbuphine? It's opioid and analgesic, and it's in first aid kits of our soldiers.
What was the medication again?
Він загубився. Видали-
Nalbuphine.
Налбуфін. Опіоїдний аналгетик.
Nalbuphine.
Невідомий.
Okay, so that's an opiate. So it's in the first aid kits for pain management. Is that correct? It's like our morphine that we have in.
Опіоїдний аналгетик. А там
Okay,
які
yeah, it's Nubane. Okay.
допомагають.
Opioid
Yep.
analgesic.
Yep. So I was
Yes, synthetic opioid.
Yep. So we do not use the opiates in our treatments for acute mental health conditions. You know, we use them for pain management in severely physically injured service members. It's interesting because we've had issues at times where we've had obviously those medications abused and used inappropriately, and those have been challenges for us to have to deal with, especially in some of our medic populations. But it is not something we use in our combat stress control or in our populations for managing mental health conditions in the deployed environment. Second, there was a question that came in through the Q&A that asked about, are there universal energy boosters that we recommend using on the front line? I think the common ones that you see are still the major standbys of caffeine is still readily used in various formats. Specifically, if you look in the rations or the meals ready to eat that our service members have, they always have coffee packets in them because that provides the caffeine and the boost. In Iraq or Afghanistan, if you walked into any of our dining facilities, there were energy drinks there that were again heavily caffeinated. I don't know if I don't think there's anyone I would particularly recommend. I clearly have a lot of concerns about them. I'd rather see service members be getting good sleep patterns. But if there were things to look at initially, it'd be in the form of caffeine, and then looking at other potential stimulants. But as mentioned, you know, it has a lot of long-term effects on the nervous system and everything, though. So I completely agree. I would not use it regularly. I would only use it periodically because you get into the issue of the exhaustion and the side effects as they're being mentioned here in the comments. And that's going to be the same with any of the stimulants, that you don't want to be looking at those long-term as a substitute for sleep, because it is going to have problems down the road.
Колеги, питання? Прошу.
Colleagues, any other questions?
Наразі.
Go ahead.
Що можна використати, яку техніку не
Which
медикаментозних
method, which non-medical technique
побутових умовах для
can be used
стресу
in combat to relieve stress
доведені
if there are proven evidence-based methods for that,
які використовують
or those that are used,
армії?
for example, in your army that you have experience with?
Sure. So the most common method we use is what we call our combat operational stress control. And that's the employment of psychological first aid. And we did do a talk, I think last year about that. And we've got a slide deck on the tenets of psychological first aid and what can be done with that. And we'd be happy to get that pushed out again to you. But that's really the frontline treatment that we use. And that is, I think, all our NATO allies use similar in various formats. It can be employed differently. But when you look, it's about the idea of early recognition of those, what are signs of the stress, what can unit leaders be doing to help minimize the stress and control it within their environment, having teams that can help provide consultation when there are questions, and then using the principles of psychological first aid for the first line treatments when necessary.
Тоді, я думаю, ми можемо завершувати, якщо питання
Then I believe we can wrap up if colleagues have no questions and if you don't mind. Yes, thank you so much. That's very rich, informative. And maybe one request from me. I wonder which protocols you grounded on, you used when you developed this presentation, because we spoke a lot about fluoxetine, but while other healthcare facilities focus on paroxetine, venlafaxine. So in this context, I wonder which protocols were you guided, Christopher, when you prepared your presentation? Maybe you could just send the links so that we could check. Thank you.
Sure. I'll be happy to send some, I'll send the articles and the chapters that will help provide some additional information on this as to which we were looking at. And that goes into greater depth and has a lot of the resources as to why we recommended these the way that we did. And much of this is based on our own experience as well within, operating within a deployed environment. Because while there are plenty of practice guidelines out there, that many of them are developed with the idea that you're working in a stable environment that's not a war zone, that has a lot of additional challenges that are not being considered when they develop those. So I'll shoot those over to Dr. Castro today that he can then send out to everyone else.
Так, я тоді попрошу тих слухачів, кому це важливо, тому що я
And
знаю,
I ask those who would like to have that, because I know I see the panelists, but if we have someone in the audience, please send me a request and I will share that with you. Yes, I'd like to have that as well, sure. And thank you so much.
Thank you all for the honor and privilege to be able to speak with you. I appreciate what the challenges you're facing and what you're dealing with, and have experienced them to a lesser degree, working in a combat zone for a number of years. But I know that you're not only working there, you're living there as well. And so not only thinking about the short term, but the long-term challenges that you'll be facing. So anything we can do to be part of helping you, it's just a privilege and an honor. So thank you. And any follow-up questions or anything that come down the road, please don't hesitate to reach out. Any way we can help, we're here for you.
Thank you, Chris. What you've done is excellent today, and Kyle and I will continue to circle back to you.
Thank you. We've been waiting for you for so long. Thank you very much for your presentation. Okay, fine. Дякую всім слухачам. Будь ласка, якщо будуть якісь питання після того, як ви осмислите
And thank you to the audience. After you've digested that, please come to us with any follow-up requests and questions. Thanks to everyone.
Дуже дякую всім.
Гарного вечора всім, бережіться.
Have a good evening and take care.